the waiting list with Southmead Development Trust, who are our providers, is more than 9 months. So yes, I can give antidepressants and give brief lifestyle advice in a 10-minute appointment. We believe that a 10-year contract is a long time. And although VitaHealth has published its data showing the uptake and success of its services, the Protect Our NHS Task Group has been questioning these figures. And indeed, Ruth and you have been having an exchange over the last year, I believe. When the contract was awarded, there was advice that evidence-based therapy, CBT, which has ongoing assessment processes. It's cheaper to run because patients can access services online or in groups. Newly qualified psychologists can run the course because it's written up in a manual with worksheets and questionnaires for patients to do at home. But I don't think it was really well known at the time by the CCG that many relational therapies also have rigorous assessment and evaluation processes and can also offer short-term work. We believe it's time to let service providers know exactly what relational therapies offer so that there can be a choice for patients. One size does not fit all. An analogy would be that a patient who presents to the GP with a skin rash, a doctor may try several prescriptions to heal it. This issue is very important because we know that there are many patients across BNSSG who are not receiving the help they need in the way they need it. An urgent review is needed. So I'm asking you if it would be possible to set up a working group to review this situation. And before I ask you if you could respond to that request, Mim is just going to bring you up to date on where we've got to in our work with this.
Hi there, so I'm Mim. So what we've been doing so far, Norma, Ruth and I, we've got 2 case studies which are kind of illustrate the fact that the kind of current provision is very effective for some people, but for quite a large amount of people is not effective simply because, as we've said, one size doesn't fit all, and people need a range of services for their different needs in terms of mental health. We've also got a leaflet which outlines our particular kind of concerns with NHS talking therapies. And we've launched a petition around these same concerns. And already, although we've kind of just started disseminating the leaflet, we've already got 3,500 signatures on that, which I think that petition's been live for a couple of weeks. And like I say, I think we just started disseminating leaflets. So it's clear that this is kind of an issue that a lot of people feel very strongly about. And we've got backing for that petition from Keep Our NHS Public and UACT, the Person-Centred Association, Psychotherapy and Counselling Union, and the Psychotherapists and Counsellors for Social Responsibility. So we really feel that there is a lot of people who feel these are issues that really need looking at. Yeah, thank you.
Thank you. And Shane, it's over to you. What you think of our request to have a working group that reviews these figures and the services that are offered.
So thank you. I suppose I have a couple of things. I don't disagree with you. One size doesn't fit all. Okay, so I do agree with you. And what we tried to do with the community mental health model, of which VitaHealth are only one part of, we were trying to create, sorry, excuse the noise outside my house, my road's very busy, you might be able to hear cars. What we tried to do was each of the 6 localities to develop an inclusive mental health model, okay, which isn't just about IAP, Vita, CBT, etc. So what I would love to do, because I'm disappointed to hear what you're telling me, because I know in some of our localities that work has moved really quickly. So, for example, one of the localities in Western Supermare, and I appreciate it's not Bristol, but it's part of our whole package. The Western locality has moved really quickly to create a genuine mental health and support service for its population. So can I, before I commit to an overall review, could I set up time for you, so Mim, Normie, whoever else, to meet with Matthew, who works for Avon and Wiltshire Partnerships. So Avon and Wiltshire Partnerships are our partner in this. They're the NHS Trust, okay? And a part of what we do, obviously, Vita Health does. But we employed Matthew to create this new model of community mental health. And where you've described to me, that new model isn't getting through where you live, okay? And I don't know which part of Bristol you're in, okay? And that's not for today. But could I set up time with Matthew, me, and yourselves to have a meeting where we say, right, what's the plan for community mental health in the place that I live? Because if we can't answer that question properly, then we've got our community mental health model wrong. Okay, so before I say we need to review the Vita Health contract, etc., I'd love to get Matthew and yourselves in the room and me to talk through the community mental health model. And clearly, Dave, from the locality's perspective, this is one that sits in your world very strongly. So I'd love to explore, because if it's missing the point that much, so that what you're telling me doesn't meet your needs, then we do have a responsibility to understand how we do meet your needs. Okay, so Dave, I mean, obviously, localities are your world. What are your thoughts?
I think that's exactly it, Shane. The community mental health service model has actually only started in the Western locality as an entity, but the 3 Bristol localities are going live with their service in December. And exactly as Shane has just said, my sense is that what the community mental health model is going to do is provide that holistic wraparound, service for all people, such that the service can adapt and flex to meet individual need. Highly engaged with the voluntary sector. We've had really extensive service user engagement in the development of those models at a locality level. So Shane's put that off of there. I think when I would want to be in the position, if we're having this conversation this time next year, once the model's been up and running in Bristol for 6 months, that you would be hearing those connections of people being connected to the right service and getting the support they need. It's just taken a bit longer to get going within the Bristol localities. But a conversation in advance of start, and then a 6 month, let's see where we are, I think would be a really positive step. But just so you are all, there has been extensive community and service user engagement in those service models, and we really hope it connects the dots in the way that you've been describing isn't happening at the moment.
Thank you. So
if you want through yourself, Ron, or directly back through yourself, normally to talk about how we set that up. But I just think it would be great, and in fact, even maybe an opportunity to go and visit the Western model, see what they're doing, and then think about, right, what does that mean for Bristol? So, but I know Matthew is working, so we'll establish Dave, myself, Matthew, yourselves, and we'll get in the room and you can see what's coming, and then you can hold us to account in 6 or 9 months' time if what we've put in place doesn't meet the way you're describing it. And for me, this is much more than an IAP contract with Vita Health. This is about a holistic mental health service for people in the community.
Okay, thank you very much.
Is that acceptable?
Yes,
No,
thank you. So Shane, can I just clarify? Will you then write to us suggesting? That's great. Thank you very much.
On the back of this, I shall drop an email through, and we'll try and get a time that suits you and suits Matthew and suits yourselves. And whether we do it virtually or face to face in Bristol or whatever, we'll work that out. But we'll set time aside.
That's lovely. Thank you very much indeed. Thank you. Thank you.
I think that's very promising. Does anyone else want to comment on or have a question on this issue? Tone.
Very brief question, Shane. What I'm hearing is very helpful, and I'm particularly grateful as part of this group that you would make time to sit down with our task force. So thank you very much for this. But my small question is, these new ventures, is there any new money?
Yes, and basically what we're trying to do is through AWP for Avon and Wiltshire and the voluntary and community sector. But Dave, do you want to sort of give an understanding of what kind of investment we're trying to place into some of this?
Across the whole community mental health service package, Tone, the new investment is circa 13 million. That covers 1-3.
Thank you.
That covers not only the kind of services that Shane's been talking to, but also specific investment in eating disorder pathways, personality disorder pathways.
Really?
However, it's a national investment framework, Tone. It was ring fence funding for providing what we've been talking through. In terms of the community mental health framework, I think the total was around 6 million distributed across the 6 localities to ensure that that funding was focused on reducing inequalities and making sure that the services were brought up to standard to meet the most vulnerable population. So it had that kind of inequality lens to it.
Sorry, I'm now slightly lost. You mentioned 13 million.
So 13 was the total. 13 was the total.
Yeah.
6 was allocated to the localities for the development of what's called the community mental health model. Tone, again, if it's helpful, again, I haven't got those. I can write to you specifically with the breakdown of the figures, but the 6 was an offshoot of the 13, if that makes more sense.
Got you. I would very much appreciate it.
I'll do that.
In fact, if you've got a copy of the initiative, I'd love to see that, because
we've got what we can share, Tone, is the open board paper that that was one of the last things the old CCG signed off before the ICB took over. So I'll get that your way.
Thank you very much.
If you just send that to me.
Okay,
David,
Ron. Yeah, sure.
I think Colette Howard has my email. I've been having communications, and I'll circulate that to others.
No problem.
Thanks, Ron.
Thank you so much for this. I think it's been very encouraging. I don't know who should go next. I'm going to leave it up to either Peggy or Barbara and Belinda, who feels most comfortable to introduce the issue that they've been assigned, so to speak, quote unquote. Does anybody have a Belinda?
Barbara, are you ready to go? Did you go?
She's on mute.
I can be.
Yeah, go
Would you
on.
like me to? Okay.
We're from the St Paul's Dental Action Groups, yeah.
Okay. Hello. Okay, I'm new to this, to say, so I've come to this campaign as someone who has lived and worked in the area for many years to build and strengthen community. I'm a community artist. I currently work in a field called Writing for Wellbeing. I felt like giving it a plug in the last thing you were talking about, because it's very good for mental health. But I would say it's very noticeable that it's a vulnerable time in our community. A lot of things have gone backwards, as we know. I felt compelled to become part of the action to save our dentists. I think they're a very important part of community, and the loss of a local dentist would be very, very damaging to community and all the vulnerable individuals in our community. It seems, this now is to do with my first question, it seems like there's been a long warning period leading up to our dentist closure, which happened on June the 30th. And all the problems in dental care. I'm learning as I go along, but it seems that a lot of what is going wrong is because of the contracts and UDAs. It's something I did ask about in a previous meeting and was told that it's something being dealt with at parliamentary level. But then I've also read that it's been known, there's been suggestions made, an outline plan, but that's actually been there for 15 years. So I wanted to ask, can we do, and the ICB do anything to help push about making the contracts and UDA figures viable? Because this is a crisis for all dentists. How do we help make this happen as quickly as possible? Yeah, would love to help. Or another idea we had was, could we in any way use our dentists and trying to get our one reopened as a role model that could be used to help elsewhere? That's the first question.
Yeah, I'm going to ask Dave to respond. Dave has the responsibility for all primary care services in the ICB. So Dave, after you.
Of course. And hello, Barbara. I think maybe we met at the action group meeting about a month or so ago. Did you come to that where we had
I've been
Bupa
to
and
one.
Yes, I think there's one where your the action group leaders were present, and we had Bupa on the call as well, and we were there. So I'm pretty sure you were there. So so a few things, Barbara. As you know, this is a new commissioning pleasure for the ICB. It has been a nationally led commission service until the 1st of April. But as you know, we the ICB took over delegated responsibility for NHS dentistry from the 1st of April, and we are really delighted that we've now got that, because it gives us the ability to work with our local dentists and work with our local communities in understanding need and understanding how we can develop services with our population. However, as you just said, that is within the confines of a national contract, which has driven the national position of NHS dentistry, which all of us would wholeheartedly agree is not fit for purpose or what we would want in terms of provision for our wider population. So what can you do? We would encourage I would certainly encourage any support or lobbying of your local. I think Thangam Debonair has been part of your, and I know she's supportive of a challenge to the UDA contract. So any lobbying on behalf of around that UDA position. However, what we are doing as an ICB is working within the contract to look at how we can better flexibly use that contract in dialogue with local dentists, in dialogue with our local community and local residents to enable contracts that are more that can be more enticing and servicing the needs of our vulnerable communities. So we have, you'll have heard us talk about stabilisation contracts and improved access to urgent care, all of which we have seen lead to increases in the number of slots available over recent months and more coming. So the value of us as an ICB is that we have that ability to engage directly with our local dentists. Now, what we are doing, and I have an offer for you, is that, as I said, we have only just taken on that responsibility as an ICB, and we are developing and forming our strategic approach to NHS dentistry. And I would welcome your input, your direct input into that development. It might be too short notice, but we do have an engagement session on Monday. And I'd very much, you'd be very welcome to attend that session. We have some local dentists, we have the local dental committee, and we have NHS England and ourselves and public health present. So I might drop you a note, Barbara, after that and the group and see if that's possible. So we are developing our local strategy. We will then be engaging with the wider community in developing that strategy. We will be as flexible and we will work within the contracts that we have as best we can to better meet local need, but it is still within that national contract framework. I can't deny that, and we would support a change to that contract. So that's the first point. But Barbara, were you going on secondly to specifically talk about St Paul's, or do you want me to? Because we are progressing the continued provision of service in St Paul's as well, which I hope you're cited on.
My second question is specific to St Paul's.
Okay, right.
Yeah. Is there anything more you want to say on the
No,
first?
no, not on the first point. So,
No,
so,
okay.
so there's a we as I said, well, I won't reiterate what I've said. Barbara, if you'd
Okay.
be willing to engage in
Yeah.
our strategy development, then that would be
Definitely
great.
very interested.
Okay.
And both myself and Belinda are people who have the skills to engage with community. You know, we've been very aware, you know, a lot of the people in the community haven't known that dentist was closing, and we're skilled in those areas as well.
Well, Barbara and Belinda, I'll drop you a note after this specifically about the session next week and your forward engagement in that.
Yeah. So my second question was, we know we have one offer on the table, and I'm aware that there have been changes made to make free dental provision possible. I wanted to ask, how do we best guarantee longevity for that provision to be sustainable? Also, that we were told there would be a statement of progress by the end of August. We haven't had that as yet. And short-term solutions were being sought to be put in place. Yeah, we don't have either yet. Could we have, can I request the statement of progress in writing?
Yeah,
and
absolutely.
To know if anything is getting any nearer to happening on the short-term provision.
Yeah, so
Thank you.
Apologies, the statement of progress is not with you, Barbara. My understanding was that my comms team were working directly with the action group in clarification of the wording, because what we wanted to provide was a kind of a joint statement. So I think I understood my team were working with Khalil in developing that statement. But if that's not arrived, I'll get onto that. I'll get onto that tomorrow. Secondly, there and just to confirm where we are, yes. Our commissioning team is as you know, in dialogue with a very interested body. We are working through the contract arrangements for that, working with Bupa in aligning the equipment, and working with the landlord to ensure that tying up the contract provision. I haven't got the specific date of when service will recommence, Barbara, but I'm assured that that, as I said, those three levels of provider, alignment with Bupa, and landlord are all moving positively forward.
Yeah,
in terms of sustainable provision, for me that comes back to having a wider ICB strategy for the development of dental care for our whole population, particularly for those communities most in need. And that's clearly where I'd want our focus of attention to be. And as I said, that's why we are engaging our local dentists and dentistry services in helping us develop that model of care.
Okay.
Could I? Have you got anything else to ask, Barbara?
Loads, but I'll just stick to that for now. And thank you. Yeah.
Okay, I'm Belinda French, and I'm part of the action group as well. And I've also an ex-patient, and I've also experienced in primary health care as a health visitor. So I wanted to ask, really, how much, new, you're talking, it's a new juncture, you've taken on dental care recently, and the UDAs, could we involve, preventive, like measuring a UDA as a unit of dental activity, could that be preventive dentistry as a UDA as well? How flexible is it? Not just treating bad teeth, but actually preventing teeth from being bad in the first place. And I also want to talk about how you involve the community, and particularly young people, because young people in the inner city area are getting very disenfranchised around their health, around there's a lot of poverty as well, and they need to be part of the consultation processes. And how do we involve them? Do you involve them? Did you involve them in the was it the next you had some other groups that you were meeting, like focus groups, next consultancy focus groups, because the young people in the area just need some hope. They need a lot of hope. They need involvement. They need agency. And it'd be really good to work with the local community, like the people who provide the food banks, who are working on the ground with young people now, because there's been a lot of incidents in the area and people are coming together and talking about how to improve the area. We need some hope in the area, we really do. And we need people to be involved, because why should a dentist just seem like this professional thing over there? It isn't. You know, it's about how we eat, you know, what we eat, what we get to eat, and we need advice for the food banks. What are we giving people through the food banks? Is it good for their teeth? You know, how are we advising young people in getting, you know, healthy food and now there's a recent report out about health hygiene poverty that came out yesterday through some charities showing that children are turning up to school with unclean teeth and with unclean clothes and things like this, and it's increased dramatically recently. You know, so how can the ICB get involved in a holistic approach to healthcare? You know, it's about really understanding a community, working with poor people, ordinary people, and how do they get to understand these things, you know? And because I was just reading a poem by Pam Ayres about, I wish I'd looked after my teeth, that made me laugh. But you know, we have a responsibility to our community to give our young people a great future, you know. And if they are struggling with their teeth and the expenses that you know, I know all about that it creates if you haven't looked after your teeth, it's really terrible, and we need to do something now. And the other thing is there's no emergency service, there's nothing that will plug the gap while we're waiting for the dentist. You know, we need something now, because people are getting toothache now. People are doing, I don't know if you've read the Toothless in England report, but people are doing drastic things to their teeth, pulling them out themselves with pliers.
I have read that report, Belinda. Yes, yeah, it's horrific. Yeah,
and also young people taking very heavy painkillers. If you take heavy painkillers over a long period of time, you can become a drug addict. It's a serious problem. Yeah. We need to look at it. We all need to be engaged in this. It's our responsibility.
So I think, Belinda, thanks for that. I think that's actually my response. This is all of our response. This is our collective responsibility. The provision of NHS dentistry, you know, is a collective kind of national. You know, we need to grip this and work with and change. It's not just the ICB, but in terms of engagement with the community, I'll go back to Shane talked about the localities previously in terms of the community mental health response. The locality partnership for inner city and east Bristol is extremely well connected with the local community and the local community groups. The membership of the locality partnership includes not only primary care, local authority, Sirona, public health, but also significant engagement from voluntary sector providers and also community engagement groups. AFI Health are members, the Care Forum are members. You know, it's never going to collect everyone, but we have a body and a group and an entity that will be engaging directly in identifying needs of the local community and working specifically with us on developing our dental strategy. If you've not heard of the partnership or want to know more, I'm very happy to talk more. Yeah. But it's that group that developed the community mental health model, and it's that group that will be engaged in our dental strategy, as well as I think the other area, Belinda, that I would want to be seeking to engagement in our hard to reach communities worked so well through the vaccination program, and that vaccination program worked because it engaged and worked with community leaders, faith leaders, youth group leaders, and we want to model that and use that in all of our engagement activity for our key strategic areas. So the dental strategy that I've just summarised that we are setting out on, I would want to be using that strategy to engage with our local communities in the engagement and listening exercise in that. So I'd reference the locality partnership and also the reach that we learned through the vaccination program, Belinda, which I know was really successful in the city and east, because it's only by engaging with those local leaders do we hear from the local communities.
Yes, I agree.
In terms of your first point about how can we use? How can UDA recognise prevention? I'm afraid that's one I'll have to get back to you on, Belinda. That's not one I've got the answer to tonight.
We need to get creative around these things, though, don't we? You know, we need to think outside the box a bit.
Indeed, we do. Indeed, we do. And what I'm saying is, Belinda, the ICB will, in terms of NHS entry, we will actively do that and work as flexibly as we can within the boundaries of the national contract. And so we are willing to do that, and we are open to doing that. And that's the benefit of us having delegated commissioning, because that couldn't happen at a more national level.
Yes, I mean, you mentioned that there is you've been developing the dental strategy.
Yes.
So is that it's not it's in development stage, is it? The strategy.
It is. That's the initial session we got on Monday.
I see.
Belinda. Yeah, which I'll drop you a note about after the session.
Yes. Okay.
Can I come in here very briefly?
Yes.
I'm not blowing my own horn, but I think David referred to working with MPs as well to highlight the situation. Darren Jones is convening a summit on dental care on the 5th of October. I think, David, you've been...
I am. I'll be there, Ron. Yeah.
I've been invited on behalf of Protector NHS to be at that meeting. So Belinda and Barbara, at some stage, we might want to talk about what issues you feel should be raised at that summit meeting. Does anyone else want to come in on this issue before we move on to Peggy, who's been very patiently waiting to talk about her issue? Does anybody else want to come in? Shane, do you want to make any comment on anything?
No, it's just that I think the point that Belinda makes about the importance of community and needing a dentist is a consequence of something else, okay? And therefore, how you work in a community to provide good food, get education, all that kind of stuff. That's really what we're trying to do with localities. That's key. If we don't get that right, we will always have people with horrific dental care who can't get access to a dentist. So the key is, can we make our locality successful in that place? We also know we have some of the most extreme inequality groups unable to get access to a dentist. And one that springs to mind in Bristol is learning disability. There are many learning disability clients who have made many years not being able to get access to a dentist, which you're aware of. So it's a range of children, learning disability, so I couldn't agree more with Belinda. That's the challenge of the strategy, and that's why we created localities. Localities are about local professionals, people's community, BCSE coming together to say, how can we fix some wicked problems? So it won't be fixed by having more dentists. It'll be fixed by going right back into how do we create better health and care.
But also, could we not create a community dentist? You know, like there's this thing about they're so professional and they need all this money, but it'd be nice to have a community dentist that really did the work in the community because they really care about the community, not because they want to earn lots of money. So I just had to get that in.
Very interesting point, Belinda. I think we could spend another half hour discussing that one, but I'm going to recognize Tone.
Thanks, Ron. Well, my point kind of follows on from yours, Belinda. I mean, as I understand it, David and Sean, you're talking about redeveloping a service within a national contract framework, which you both regard as not fit for purpose. Now, this is a kind of structural, it's not a kind of structural question. This is a structural question. What would happen if you said words to the effect of, sod the national contract, we're going to go it alone on what we believe is right? What would actually happen?
Well, if at the extreme, what would happen is the ICB wouldn't have the authority to spend money in that way. And as a public body, what would happen is I've broken the law. I mean, that's at the extreme. I've broken the law.
Okay.
By choosing to pay for something outside of a statutory contract. So that's an extreme. Now, would I go to prison? Don't know. But that's taking that comment to the extreme. I think what's most important is how can we work within it to really push the boundaries of it. But if I were to start paying people outside of contractual terms, I'm breaking the law.
That's kind of interesting because as I understand it, at a government level, the whole point of ICBs is to further fragment the National Health Service and basically create a competitive free-for-all within that bit of the system. So
I wouldn't agree with you there.
Organisations, for example, offering consultants over the odds to come into work during strikes. So I understand what you're saying, that there's a constraint of the law, but it seems rather odd. And it seems that would be acting against the whole point.
I think we could probably sit all day and debate this one to great lengths, Tone. All I know is that contractually that's the position I would be in.
Yeah.
I think what would be more equally important is can we get the most out of the contractual framework? And that's what we've got to try and do. And also hope that we can get at a very, very senior governmental level with enough people pushing the button, we can change the contract. But I have to work within the frame that we've been given.
Where should we be pushing to help you change the contract?
I think that's going back to Dave's point about, with regards to MPs and others pushing up to government. Because the contract at a governmental level hasn't delivered the outcomes we want to deliver. So we have certainly made known that we don't feel the contract is fit and is not helping us deliver good dental care. I think others are also trying to do the same thing, Tom.
Yeah, I mean, one of the problems we have here.
Very briefly to answer your question. I'm, for my sins, so to speak, I'm sitting on another group convened by NHS England. It's called the NHS Dental Reform System Group. I'm one of 3 patient representatives nationally. It includes NHS England officials who are responsible for reviewing the contract. And there's a consensus that the contract is not fit for purpose. It is basically driving dentists out of the NHS system, and changes are going to be required. And the purpose of the group is to come up with proposals to NHS England to revise the contract. So, and we have a meeting, I think, on the 11th of October, which is a Monday. So I can report back to the group about how progress is being made there. Sorry to interrupt, Shane, but just wanted to answer Tone's question. Barbara, I'm sorry, I didn't mean to overlook you.
Fine. Do you mind if I just ask something quickly? It's just when you were saying about, I really understand what you were saying there about, you can't work outside the contract. But then my understanding is for the St Paul's dentist to be viable, you're allowed to do some things. And that goes with my question about how do we make the new dentists coming in practice be sustainable? Do you think any changes that you're making can be made with a long-term commitment to them? You do.
But Barbara, sorry. I would only reiterate what I've said and only supports what Shane's been saying is we are and will continue to work as flexibly as we can within the confines of the national contract to get the right service for our population. Yes, we are talking about, but all of that would still make sure that Shane doesn't end up with a court injunction against him. We are working within the confines of the contract, but we are working as best we can to flex that contract and flex where we can to ensure we get sustainable provision to our most vulnerable communities. That's what we're doing, still within the confines of the national contract, though.
And where that could be long term.
And certainly what we would then do is look to take any lessons that we learned from that process to our wider dentistry strategy to secure provision for our other hard to reach communities, Barbara.
Thank you. That's a really good answer. Thank you. I just want to add as well, we're planning to do a fun day in our area to make the wider community more aware of what's happening. So if you'd be interested in any involvement or anything.
Yeah, do stay in touch with that, Barbara. Absolutely.
Okay, thank you very much.
Thank you for this. It's been a very interesting discussion. I'm keeping an eye on the clock here. We only have about a half hour left to our meeting. So I'm going to turn the floor over, so to speak, to Peggy, and you will introduce the issue that you want to discuss. Thank you.
Okay, I'm Peggy Woodward, and I'm a retired nurse midwife from the other half of the island of Ireland, Shane. But I came over here in 1969, one of those immigrants who they hated at the time. But anyway, I'm passionate about the NHS, having experienced the first 18 years of my life with the two-tier system. And so I'm devoting the rest of my life to campaigning to try to counter the appalling damage that's been done to it over the last 4 decades, but particularly over the last 13 years. I want to just talk about, well, I've been volunteered to talk about community diagnostic centres. And this whole meeting has been so interesting, I'm finding it difficult to keep my thread, honestly. Community diagnostic centres, I mean, to start with, they've been sold another wheeze by the government to pretend they're actually doing something about the shocking waiting list and waiting times. That they will provide community diagnostic centres in people's local areas, in their supermarkets, just there you can go and have your X-ray, your MRI. I mean, it's crazy. As far as I know, there aren't many of them open. I do know of one in Wales which opened and closed again. They're mostly private. Well, quite a few of them are going to be privately run, because this is also being touted, and I quote a government minister saying that it's going to turbocharge the private sector, thereby boosting capacity in the NHS. So, you know, like the cataracts, you know, let's give all the money to the private companies who are only in it for profit. Now, where are they going to get the staff? Where are they going to get the equipment? The one in Wales that I've heard about, they decided they couldn't make money because they couldn't run a machine that has to be kept on all the time because they were doing very few scans. So it's this crazy system. And first of all, I probably need to ask the question is, are there any in Bristol? If there are how are you planning to control them and to make sure you don't end up wasting or having to allocate money that we can't afford in the NHS to them? If there aren't, will you try and stop them happening? Okay. Will you have that power?
So in terms of community diagnostic centre, and apologies, my screen's gone very dark, and no matter where I'm moving in the room, I'm staying quite dark, so apologies. Community diagnostic centres, as you say, nationally, were created as a concept. And we have been part of a national conversation, and 2 of them are coming to the southwest, to Bristol, North Somerset and South Gloss. One is coming to Weston, so on the edge of Weston-super-Mare, and one is coming to Cribs Causeway. Now, I don't know where, I don't have the detail of whereabouts in Cribs Causeway. For us, we have horrific waiting lists for diagnostics. We've modelled out the capacity we need, and we believe this will give us an opportunity to get MRI, CT, plain film, ultrasound access much quicker, because the capacity we have in BNSSG is full. So we're running at full capacity with the equipment and staff that we have, and therefore this is additional capacity. We have worked with a national team to model, because the greatest fear I would have is somebody comes along and builds one of these and it's empty, okay, in terms of the patients don't come, okay. Now, I know what our waiting lists are. I know that we have over 3 years worth of work that we cannot deliver within our current NHS facilities, and therefore the contract that has been let a part of the national scheme would give us that capacity. So timing wise, it is into next year before it's likely to see either of those centres open, but it is very clear this was additional money that was coming centrally to us for this particular function. We have been involved in the contract to try and make sure the contract is sound, to make sure it meets our needs, and it is likely they will open early next year, both in Cribs Causeway and Weston. And for me, it will give patients access to stuff they don't have access to at the moment. Much like the conversation at the beginning, once we get past this massive backlog. The long term is that we want to return back to the normal match of capacity and demand in the NHS, but this will give us an amount of capacity that we don't have at the moment.
It sounds to me, maybe I'm being cynical, that you've been given money by the government for this, for a need, but actually so that their private cronies can make money out of it, because the private sector is struggling actually, but despite what it's done. But the other thing that I'd want to say is increase in diagnostic capacity. It must be matched by increased capacity to deliver treatment. Yeah. And if you do your scan, you can't have your treatment. It doesn't really move you forward. I mean, I know I wouldn't want your job for all the tea in China, but it's just, and the staffing, where are the staff coming from?
Yeah.
When it finishes.
That's a really good point. So a lot of the staffing may work across our own facilities and across the diagnostic centres. So some of that may be the case. They also will have a responsibility to bring staff with them. Much of diagnostics, as you know, can be analysed and reported on offshore. So it could be overnight the reporting goes and that kind of stuff. And I know certainly in my experience back in Northern Ireland, when we had a real shortage of radiographers and radiologists, we did a lot of the scanning in the day, but the reporting is done at night in Australia, because that's how you can get reporting done. So I'm pretty sure they'll look at all kinds of options. For me, what this will give me is I can get patients to a diagnostic test. And I appreciate many diagnostics lead to treatment. Many diagnostics lead to discharge because the diagnostic has proven that they don't have something scary and horrible. So I want to get people diagnosed, but I don't take away from the point is that if it then ends up they've been diagnosed and then suddenly they wait a year for treatment, that's not helpful either. So I totally accept that. But many people having a scan will confirm a good thing, not necessarily treatment. And I'd rather get that done as well. So in terms of getting capacity, I think that's an important thing. But actually what I want to do is get back to balance where I don't have people waiting. And the best way I can do that is clear the backlog and then rebuild capacity within the NHS. I
appreciate that. I just think always beware Greek sparing gifts.
I know.
This is a political marketing tool, and you may get increased demand like those private GP services discovered that when you unlimited diagnostics for all. I want a scan, I will get one. And now they have this, community diagnostics. So the demand may increase, but the worried well as well.
Yeah, I hope, and it's interesting. I mean, in terms of access to diagnostics, and Peggy, having worked in the health service, access to diagnostics does require a professional referral from a GP or from other consultants, etc. So I hope having access to something won't create demand. Demand is created by a professional assessing whether you need a diagnostic test. However, there has been evidence in the past that it can increase clinicians' desire to do diagnostics because the capacity is there, just to be sure. And I think that's something we've got to be very careful that it doesn't change referral patterns so that people are referring too easily, because we also know diagnostics can be dangerous. Radiology is not a thing you really want to put your loved one through too often. So there are massive IRMA guidelines around radiology, and I'd be very, very disappointed if clinicians started, just because there is a service, referring people to that.
Mike, do you want to comment on this? So
yes.
Thank you.
Thanks, Peggy, and thanks, Shane. I guess this is where I kind of go a bit political with the small p, because this Protect Our NHS, and David, we've been campaigning on a number of issues during the years of the CCG. But on this one, I think I'm personally going to be very committed to keeping an eye on InHealth, who are the contractors, these new diagnostic centres, because as Peggy says quite rightly, and this is where I think this is why we're campaigning, this is why we're not part of the ICB, that we want to keep you to account, in that this InHealth is basically a private company founded by a British entrepreneur who is getting money out of the NHS, which should be going to the ICB, and the NHS. And I suppose that's all I really want to say, is that the government has basically given a private healthcare lobbyist close to Downing Street, a friend of Rishi Sunak, this contract. And I think it's absolutely disgraceful. And I know you as the ICB are in a really difficult position. But that's why, as a campaign group like us, we will be keeping an eye on what's going to happen here. And I hope you recognise that that's our role in terms of keeping the ICB to account and us campaigning basically against people like InHealth taking on these contracts.
Yeah, and I do respect that, Mike. I really do, and I respect the role that this as a lobby group plays. And I also hope and know that you respect the fact that if I can get patients seen through this, appropriately seen quickly, and then find a way to rebalance the system, that can be good for patients to begin with. If this is the long-term answer to our health service, as I said to you before, then I do fear, okay? But for me, I have waiting lists of 2 years, 3 years for some people who need diagnostic tests. And this will give me a way of getting patients their test. And so I really appreciate the role you play with lobbying. And I hope you can understand the role I'm trying to play as a chief executive at the moment is how can I get as many people access to the service that they need? But I completely acknowledge the position, which is if we keep going down that path, then what does it do to the long-term fabric of the NHS? And I totally respect that position, Mike.
Thank you, Shane.
Does anyone else want to come in on this issue? If not, I'm Tone, you raising your hand, okay? Tone?
Thanks. Clearly, you're not going to tell us the details of the contract, but taking what you've said and Mike's point, which is of course our point, and I completely agree with, how are InHealth being paid? I mean, are they being paid to run a service with an open-ended number of customers, or are they being paid per diagnostic test?
The contract is based on an agreed predicted volume that they must deliver at a particular price, and that's something which is a national approach. Okay, so they will not be paid if they don't do the work, and that's been agreed as part of the contract. We have estimated based on the demand we know of people both on our wait list and projected how much volume that will be. So that's the way that it works. And clearly, if we don't use them, I say we, as Peggy clearly said, and this is central government money. We haven't had to use local government, local health service money for this, but the money comes to us to then pay them. And therefore, if they don't do the work, they don't get paid.
So basically, it's an old style service level agreement.
It is, yeah. And it's been estimated at a certain volume based on the demand that we know.
Right. Thank you.
Yeah.
Any other questions on this issue, either for Shane or for David? If not, I'm going to thank both of them for giving up.
Thank you.
An hour and a half of actually, yeah, almost, yeah, an hour and a half of their time to have a conversation with us. And I found the discussion very, very enlightening, and has shed light on a number of issues, and hopefully we'll be able to continue this conversation in the future.
And if it's okay, Ron, we will follow up on the community mental health conversation with Normie and with forgive me, I've forgotten the lady's name, but I will I have it in my notes, so apologies.
Belinda is her name.
Belinda, okay. And then obviously no, it wasn't Belinda.
Oh, it's Mim.
It was Mim.
Mim, sorry.
Great. So we'll go back to you, Ron, with that and setting up the time the community health model. Dave, obviously a lot of conversation around dentistry, so absolutely linking in through the dentistry.
Yep, all of that.
so that we can follow both of those up. Can I just say, and I said this last time, you know, I am always very happy to come to this group, and I'm always very happy to be honest and open and say, this is what we're trying to do. I hope you can see that. We don't have all the answers. We really don't. But I'm more than happy. And I do hope the mental health conversation, the dental conversation will help you see that we are trying to move some stuff in the right direction. We really are. And as I say, Ron, more than happy. You know, I know you meet very regularly, but, you know, as I say, a couple of times a year, if you want me to come along, update where we are, very happy to do so, Ron.
Excellent. Thank you so much.
Okay, look, have a good rest of the meeting.
Okay,
Thank you all very much.
Thank
All the
you.
best. Great conversation.
Thank
Thank
you.
you.
Thank you.
Bye.
Hello, everyone. You got 15 minutes left. Does anybody have any thoughts on? Peggy, you don't have to say anything. I think your verbal response, I think, was enough, or your physical was enough.
Well, I'm not allowed to say anything else.
Well, you
can
could
say
if
what you
wanted.
like,
Is there
Peggy.
any reflections on what just took place?
How
You
much
don't-
do these guys get paid?
Oh, who knows? Triple figures.
I mean, really.
Norma.
I see our meetings with Shane as an opportunity not just to have a dialogue and question, but also informative, you know, for him to inform us, for us to inform him. So I think by sort of actually putting our point of view and our worries and concerns and question and confront some of this, I think is an education as well. I think that's part of our role, which is we're thinking about things in a different way. We're not employed, you know, it's not our job, and our salary is not dependent on how we respond. And I wonder if he doesn't also, it's challenging, but if he doesn't also appreciate our honesty and our thinking, because I'm not sure he could do this outside of the sphere of his workplace.
Sorry, Norma, can you say the last bit again? Like, you're not sure he can do this?
I'm not sure he can do that within the confines of his workplace.
Ah.
You know, to think in this way, because his job's on the line. He's got to do as he's told. He's got a salary and a family to keep. So coming outside to us to explore this, to hear Peggy, to have our questions, gives him an opportunity to think. I don't know where that leaves him morally in his job, but it is an opportunity to come away and think about things.
Well, I agree, Norma. I don't think we could have this kind of discussion with him at the ICB.
No.
No way. Those meetings are very bureaucratic, very formalistic. So I do agree. It gives him an opportunity to hear from us as patient activists what we are concerned about. Whether or not that makes a difference overall on the policies or the decisions made by the ICB is another matter. Peggy, you want to say anything? I didn't mean to cut you off before by saying that your physical expression said it all, but do you have anything to say?
No. I mean, it was an energizing meeting. I think it is a very, you know, fair play to him. He comes out and, you know, yeah, I found it educational as well, actually.
Yeah, but essentially what he's saying is, I'm a good guy, my hands are tied, Gov.
But he's giving us a little bit more information than we'd get, I think, any other way.
We're certainly getting more information from him than we got from the CCG. Absolutely. And I think, you know, if I do get the papers he said he's going to send, great. I think, Mike, your idea of really watching this diagnostic centre is a brilliant one, and I will help you on that if you wish.
I mean, the point I didn't want to make at the meeting, because I didn't want to be too interventionist, but it was a point that John Lister made in the lowdown article on the diagnostic centers. He says the alternative, when people talk about NHS capacity, they could easily rent facilities.
Yeah.
Why didn't rent facilities to open up diagnostic centers?
But they still need to staff.
Why do you have to contract to a provider to actually do the work on a facility. Because if these facilities don't exist yet, where are they going to be established? Where's the private provider going to find a facility?
Well, presumably a large retailer.
They're going to probably have to rent. They're going to have to probably rent space. Why couldn't the NHS do that? Why couldn't
I don't quite agree with you there, Ron. I mean, I've been spending the whole day looking this up, and also heard something from a family member who, in Wales. And I mean, renting, it wouldn't really, they had a centre where the company just walked away and left. They'd employed the staff, and then they told all the staff, you haven't got jobs anymore because we're not making enough money out of this, because our incredibly expensive scanner, you can do things like blood tests and simple stuff, but a thing that does an MRI has to be, they become obsolete in a couple of years. They're incredibly expensive. They have to be maintained. They often have to be kept on 24 hours a day, or, so if they were doing this small number of images, they weren't making the money. So these people were told, no, you haven't got a job anymore. So I think it's not as simple as that. Plus, there's the issue of where does the staff come from? And it's the same pool. It's the same managers, trained radiographers. So actually, I hear what you say, Ron, and you gave me that as an idea to look up, but I don't think that, I think John Lister may not be correct there.
Well, there are hospitals in London with MRI scans in container lorries in the car park.
But they're actually they're part of the NHS. I mean, we had those.
Well, I don't know if they're part of the NHS or rented.
We had those outside the BRI years ago, years and years ago, when my friend had MS first. So, that's not a new thing. It's not, they're saying this is patient choice. Don't have to, that's why they've chosen Western, because as Western people used to complain like mad about having to come in to the diabetes clinic. They're saying you get the choice of having your stuff out there in Western. So they're probably going to throw money. I don't mean the ICB. The government's going to throw money as a vote winner, saying we care about this deprived area. So, it's all political spin, I think. It's just...
You want to come in, Jackie?
Oh, yeah. I completely agree with you, Peggy. I mean, the other thing is, why Cribs Causeway? Because actually, if you're thinking about where the deprived populations in Bristol are, the people with the real health needs that aren't being met, they're not anywhere near Cribs Causeway. And I agree with you, it's a similar thing to the Western thing. It's kind of like, it's kind of taking the heat off them a bit in terms of people who moan and complain. And I mean, yeah, sure, there are deprived communities in South Gloss, we know that. But actually, it's a bit of a similar argument to St Paul's dentists, isn't it? That actually you need to put the services where the health need is. And I mean, I've just thought it was really interesting for me because I didn't come to the previous one where Shane Devlin was here. And, just everything boils down to and goes back to central government and money, doesn't it? There is nothing, there's no other, you can't spread it. It can't spread it even thinner. It's just impossible to. And so, they kind of, the way he was sort of talking about, they're really thinking about local needs and stuff. They're not, are they?
Probably are, and probably getting a headache.
Leslie, you want to come in on this? I want to make sure give everyone an opportunity to give some feedback. Leslie?
Yeah. I suspect the reason they're looking at Cribs Causeway is because it's a main transport hub. Most areas have buses that go to Cribs Causeway because of the shopping there. So I suspect that's part of it. I also wonder on the part of the actual buildings. I mean, we had the whole Nightingale set up, didn't we? And I mean, we still go to UE for our COVID jabs, and they've still got the beds and all the equipment there. So I don't know why they're not capitalising on that and using that, which is already set up.
Good point. Norma.
Well, the business of money, I can't remember if it was you, Tone, who asked him when we were talking about the mental health services, whether or not there would be any more money. And he said yes. And I went, Peggy, do you remember when we went to the locality ICB meeting, and that Dr. Kirsty Alexander asked him the same question in Southmead when they talked about the community development sort of health things that they were doing there. And she said, so if I come to you with some projects, is there any point? Is there any more money? And he said, yes, there is. Yes. Now, I suppose tonight and when we were at the ICB meeting, we didn't say how much and when is it going to be available. I mean, I suppose we didn't ask that. Maybe we should have
No, I
asked.
did ask him how much.
Yeah, but you didn't ask how much, did you?
I did.
6
And the
million.
answer was 13.
But it's 6 million over the new initiative over 6 localities. So it's $1 million for each locality, which is really not that much money when you think about
Well, I
it.
was going to say.
And then there's also, on top of that, to bring it up to 13 million. I'm looking for my notes.
Yeah.
So it's $1 million for a locality and then another 7 across. And the interesting thing was, I don't know if you picked this up, Norma, he also said that that was going to cover eating disorder services and personality disorder services, which have been nationally run previously.
Wow.
Yeah.
Yeah.
So
Very
we can start asking difficult questions about, you know, my anorexic 13-year-old niece. Is she going to be sent to Aberystwyth for treatment? Or are we going to, you know, give some money to Riverside so they can actually start treating more kids?
Yeah. I think what I'm concerned about is I do believe he will set up this meeting, and then Ruth and Mim and I sort of circulated the petition and the leaflet to counselling agencies, and I've had an email from BACP, that's the British Association for Counselling and Psychotherapists, with from somebody there saying we're keen to sort of meet you and explore this topic further. My concern is the small number in our task group, because I don't actually feel, I mean, Mim's taking a month, Ruth's taken a month out, and I'm not sure how much I can do of this, and I feel that we need our task group to grow in order to attend these meetings and spend the time and the thought to actually developing what's needed. And if you remember, Tone, we put in a lot of work. Do you remember when we were looking right at the beginning? And I don't feel as if I've got it anymore because I'm not working in the field. So I feel very out of touch. And I just wonder how we can recruit more members in Protect Our NHS onto this task group, because it's quite complicated, really. It's quite a complicated issue about what services are offered and to whom. Yeah, that's a query for me. Is it just about energy and resources? Because it's a lot to sort of explore and research.
Yeah. One thing that just occurs to me on recruitment, Norma, is that in her presentation, Mim talked about the organisations like, you know, psychotherapists and counsellors for social responsibility. I mean, maybe we need to canvass them along with CAP, and maybe get try and get an article in the BACP journal or even the UKCP journal, which A, outlines what we're doing, or what you're doing, sorry, but what's being done, and also asks for people to join us, because you know, I'm sure we can find a patient, a volume of patients who might have time or energy to get involved. But as you say, it's a fairly complex issue. And if we can get to the counsellors and psychotherapists like myself, who work in private practice and would love to be employed by the NHS, I think I'm making an offer there, Norma.
Thank you, Tone. Thank you.
I've got another month before I go back to work.
Norma, for
I'm only going back to work for 1.5 days so far. So,
but sorry for interrupting, Mike. Tom, sorry. For the very reasons you specified, the complexity of the issues and the fact that people have to be involved in mental health services, I think the task force should not be limited to Protect Our NHS. I think we might have to develop a wider task force drawing on the other organizations that Norma, that you mentioned and that Mim mentioned. And maybe that's the way to go.
For sure. I think for sure.
I don't know if anyone else within Protect Our NHS who has the capacity, so to speak, to be involved in that task force.
Well, certainly the London group that produced, you know, the material I sent to you, I'm sure has got energy. You remember that, Norma?
Yeah.
Right, it's 8:44.
Okay. Can I tell you something very local?
we have one more minute unless
Okay,
people.
I'm going to tell you something very local.
1 minute.
We
yeah.
got over 200 postcards at the festival at the weekend.
Oh, it's done.
Very pleased with ourselves. They turn out to, let's say 100. It's 98 envelopes to individual MPs, which will cost us 100 times 75p to post. I've been in contact with the House of Commons, and there is a system whereby we can send mail in bulk, but it will be slower. So do you want me to reduce the bill from 70 quid to about 30 quid, but it will take probably 2 weeks to get there? Or should we just whack the stamps on and get on with it? Peggy?
There's no hurry, was there?
No, I think it's okay to reduce, may have a 2-week wait, because it's an ongoing campaign.
Exactly.
I have to confess,
I think
last year.
probably Keith is getting a bit nervous about how much money we're spending on postage.
Well, we're not spending any money on rent. He can suck it up.
And I've just sent him a bill for £167 for printing of flyers and leaflets and petitions.
We've got £2.5 grand. Come on.
I know. So
anyway, Peggy was going to say something.
Second-class stamps are 75p each.
Yeah.
It soon mounts up. I have to confess to Sarah now. Last year we posted. Sarah did one day, I did the other, and I posted all my lot, which was 100 and something, I think, wasn't it, in one envelope to the House of Commons. And Sarah told me after that wouldn't work, but I didn't tell her I'd actually already done it. So I'm really relieved to know that they would still have got there.
Well,
I did put my address.
That's very interesting, because I spoke to the House of Commons this morning, and they told me specifically not to do that.
Yeah. Okay. Well.
But how did you find out that you? How do you find out
From the House of Commons, by talking to their logistics team and their secure postal service.
Yeah.
Yeah. See, I put a sticker on the back with my name, and nothing came back. So I just prayed that they all got there last year.
I was waving her hand.
So we can.
Are you going? I thought she wanted to talk. She didn't
join the conversation.
She talked with her feet, so to speak. She's gone. I thought I don't know if we have time or energy to discuss the debriefing on the Forwards Festival stall. Mike, I don't know if you're still here.
Doesn't look like it.
Video.
I'm going to go now, Ron. I need to leave.
I think we could defer this issue to the next meeting on the 19th, if that's okay with people, because it's been a long meeting and a very demanding meeting as well. People have to be in tune for the discussion with David and Shane. So I think on that note, I've circulated the treasurer's report earlier today. You could take a look at it. We have 2,200 pounds in our kitty. So we're doing fairly well on that front. Anyway, have a great week. And
Thank you.
I'll see some of you possibly on the picket line during the week of the 19th, because the junior doctors and the consultants are going out together at some stage in that week. I'll circulate the details. But anyway, our next meeting is 2 weeks from today, then on the 19th.
Thank you.
I'll see you at the stall. Otherwise, yep, Peggy.
Thank you. Bye-bye, everybody. Bye-bye.
Bye-bye.
Bye-bye.